Atrial fibrillation is an irregular rhythm of the heart. It increases in frequency with age and with other conditions such as high blood pressure. And it's a significant cause of stroke because it leads to clots forming in the heart, which can break off and go up to the brain, block an artery and give a stroke. And so atrial fibrillation causes about a quarter of all strokes. And we have very effective treatments if we identify atrial fibrillation to prevent stroke. With anticoagulation was initially warfarin. We now have newer drugs, which are somewhat easier to take with less monitoring. And that reduces the risk of stroke in a higher risk patient over the age of 65. Untreated, the risk might be around 8% a year. And then anticoagulation will reduce that down to 2 or 3% a year. So that's a big treatment effect. So you can prevent many strokes by finding people who've got atrial fibrillation and getting them onto anticoagulation. And that's been a major aim of many healthcare systems, and it was in the UK with a number of initiatives prior to the pandemic. But what happened during the pandemic was people just weren't having contact with healthcare professionals because of the lockdown and to avoid infection. So these checks were not happening. And we know that there was about a 43% reduction in new cardiovascular diagnoses, including atrial fibrillation in the UK in one study. And in the first lockdown in Denmark, they had a 47% reduction in the identification of AF compared to what they were finding for a similar time period a year before when they didn't have a lockdown. So we know fewer people with atrial fibrillation were being identified because of the pandemic. And we're still seeing some problems with this now because of the pressures on healthcare services and move to still virtual consultations. So we're losing some of that opportunistic opportunity to identify people with atrial fibrillation. Obviously, it was a big challenge for health systems to deliver a vaccination to large numbers of people in a relatively short period of time. So, however, there were some primary care clinics running vaccination clinics who were interested in the opportunity because of particular challenges in their community to see if they could identify people with AF. And so we worked with particularly one clinic in a deprived area where you get higher burdens of cardiovascular disease to develop a protocol to think through how you could do this effectively. The traditional way of finding AF is to do a pulse check, and if it's irregular, to do a 12-lead ECG. That leads to quite a lot of false positives. It's sensitive. You'll pick up most people with atrial fibrillation, over 90%, with a pulse check, manual pulse check, but you get lots of people with odd, what they call ectopic beats, or just other types of arrhythmia which are not problematic. So you end up having to do a lot of ECGs. Whereas if you use some of the newer single lead devices, there's a number of them available, that tells you much more accurately whether the patient's got atrial fibrillation. So that means you can have a much more effective flow of patients through the system, which is what you need to think about. So the clinic we work with, and most clinics have used these single lead devices that can be used by any healthcare professional or even non-healthcare professionals who are trained how to teach patients to use them. We introduced a cleaning system, so these were swapped down between patients, so there was no risk of infection. And then sort out what information on an A5 card you give to the patient, saying, we have found you have atrial fibrillation, please go and see your doctor, we will notify them, etc. So we wrote that up in a paper in the European Heart Journal, just describing the approach you can take to make every contact count. And it's one of the things we're thinking about now. Traditional approach has been to have health checks in everybody over 40. But really, whenever you've got the opportunity to identify somebody with cardiovascular risk, be that hypertension, atrial fibrillation, or elevated blood lipids, you want to be able to do that. So I think the major conclusion is it's feasible. You can do this, and particularly if you in an area where the detection of atrial fibrillation is low and you know you've got a problem, it's worth thinking about how you do that. We would advise restricting it to people over 65, which is what the guidelines say, of where to look for atrial fibrillation rather than doing it in younger people. We don't think that is a value, and you create a lot of false signals and the like. And think about it in this approach in other areas where you've got high volumes of people coming through. So flu vaccination clinics are an obvious one as well, and people indeed have done the occasional, have used those in the past for identifying hypertension, for example.